So, Assalamualaikum and good afternoon, everyone who's joining us. Thank you for joining. We can see that the number of participants is steadily rising. So thank you so much for joining us today for the webinar. Maybe we'll just give it another minute or so, and then I'll start the introductions. Yeah. Okay. So we have up to 60 people or so. Hi, hello, Amma. Good afternoon. If someone can just give a little indication that the sound system is okay. The audience, yeah? Okay, great. Thank you. Thank you, Afiq. Okay, great. Thank you so much, Dr. Tang. Okay, then I think, shall we start, Prof. Bullen? Yeah? Okay. All right. So, Assalamualaikum and good afternoon to everyone. Thank you so much. It's lovely to see all of you joining us today for the Zoom seminar. And it's really my great pleasure to be able to host this seminar together with Dr. T. Kok King and Prof. Noran. And also to, of course, introduce you to Prof. Chris Bullen. So Prof. Bullen is joining us from New Zealand today, where he is a professor of public health in the School of Population Health at the University of Auckland. He is currently reviewing our faculty research programs as the external assessor and is working with us across the seas all this week as part of this exercise. In fact, Prof. Bullen is no stranger to University Malaya or the Faculty of Medicine and has visited us when he was able to several times over the last few years. And he has been a University Malaya academic icon since 2017. So I'm sure you're keen to hear his talk, but just permit me a few minutes to share some further background about Prof. Bullen. So apart from his role as a professor of public health at the University of Auckland, he also wears many hats. He's the director of the National Institute for Health Innovation at the University of Auckland. And this is a multidisciplinary research group which focuses on developing innovative solutions to improving people's health in New Zealand and across the globe. He's also the director of the university's postgraduate education program in public health, as well as a fellow of the Faculty of Public Health Medicine, Royal Australasian College of Physicians, a fellow of the New Zealand College of Public Health Medicine, and also a member of the Society for Research on Nicotine and Tobacco. So after obtaining his medical degree, he went on to be awarded a doctorate in community medicine from the University of Auckland on tobacco cessation and has continued working in this area using innovative intervention programs to stop tobacco addiction, and has shared his findings in over 200 publications, book chapters, and conference papers. He also does research on other addictive behaviors such as alcohol and gambling addiction, and has worked on other areas such as in housing and health, heart disease prevention and treatment, and using the latest technologies in order to improve delivery of these intervention programs. So today, he will be sharing his thoughts about a very timely topic that has affected us all. And as co-chair of a Lancet COVID-19 Commission task force on public health measures to suppress the pandemic, his his seminar titled The Public Health Response to COVID-19, Perspectives and Lessons from New Zealand and elsewhere, I'm sure will give us some things to think about as we move forward. So now I'd like to hand the session over to Prof. Bullen. Thank you.
Thank you, Terima kasih, and Salamat, everybody. Wonderful to be here. It's a great honor and privilege to work with colleagues in Malaysia. It's my second home, and I've had the pleasure of spending many weeks, probably months in total, traveling throughout Malaysia, from the coast to the highest mountain even, and having a wonderful experience, and really enjoyed my visits to and working with colleagues there, and I continue to do that through the current piece of work, but I'm also co-supervising a student, sometimes examining theses and various other things. So it's a great pleasure for me to be here today with you. It's your morning, it's my, or midday, it's my late afternoon. I'm just going to share my screen and we'll continue with my talk. And hopefully that will come up and you'll be able to see. All right, so, okay, good. So what I want to talk about is really the role of public health, first of all in containing the COVID-19 pandemic, but also then zoom out somewhat to think about the wider mandate of public health. And I believe we could say that public health really is a movement for health equity. And how can we learn from our experience with historical epidemics and our current COVID experience to try and prevent and do better with the current pandemic, but also future pandemics which we face, perhaps not always infectious, but of another sort. In March last year, this was a little clipping from the New Zealand Herald, which is a national newspaper in New Zealand, and slightly tongue-in-cheek, but the first 4 headlines most commonly looked at stories were all to do with the arrival of coronavirus in New Zealand, the first cases. The 5th one is a slightly odd one, and I suppose people are fascinated when they feel uncertain, not with fear, but they also think a lot about food and security. Peanuts flavored ice cream bars hit New Zealand stores. Anyway, this is the story of the COVID pandemic in New Zealand. We had a peak in March and April, and then we locked down the whole country for about 5 weeks in a very short, sharp fashion, which brought all community transmission to an end very, very quickly. And we've pursued what we've called an elimination strategy, which is really using all means possible to contain and control community transmission to a level where we can manage with contact tracing and where our hospitals are not getting overloaded. And so there have been little outbreaks from time to time that have been easily contained with local lockdowns in particular areas, but particularly just excellent contact tracing that's continued to improve, managed isolation and quarantine at the borders, regular testing and surveillance, which I'll come to. And then the game changed. You can see the highlight there with the arrow when we had the first reported case, and we were laughed at in the international press for going into a national lockdown with 1 case of Delta. But within a few days, we had over 50 cases. And this total Delta outbreak, the total number of cases will probably exceed 1,000. But as you can see, again, the epidemic curve has declined rapidly with the lockdown, which now only applies to my city of Auckland, population about 1.6 million. So we're in lockdown, hopefully for only about another week, only 14 cases reported today. And that's been the situation for about 7 or 8 days now. So we're getting on top of it again, which is reassuring. So we've been applying, all those measures with which you are no doubt familiar about staying home. We call it staying home in your bubble. Other than people who are essential workers, We're allowed to have safe recreational travel, but otherwise travel is severely limited. There are border patrols around the border of the Auckland region, and people are penalised if they try and break the borders. All public gatherings are cancelled, public facilities are closed, and all schools are closed at the moment. The messaging about physical distancing, social distancing, 2 meters. We have managed isolation and quarantine facilities for people coming into the borders or people who are diagnosed as having had a positive PCR test. They go into a managed isolation facility, transferred to hospital only if they are unwell, sufficient to need respiratory support, etc. And then, of course, mask wearing. It's not mandatory except on public transport, but there is heavy social pressure for people to be wearing masks when in public. The chap on the right in the photograph wearing the mask is actually Dr. Michael Baker, who's our preeminent epidemiologist, who's presented unceasingly on the media throughout the duration of the epidemic. Now we've got, those are sort of old-fashioned public health tools: physical distancing, isolation, quarantine, and counting the cases, drawing epidemic curves. But as you know, and I'm sure you've experienced, there are additional new tools that we have to draw on for public health intervention in the face of this particular pandemic. We've been using QR code scanning when going into any building premises so that people can track where they've been in the last 14 days in case they happen to be a contact of the case. And then we've got all the records of their whereabouts over the previous 14 days. And we can see the rates of registration and scanning. They go up and down as people become complacent when one outbreak settles down, and then they forget about it until there's another outbreak, such as human nature. Gene sequencing has also been incredibly important in identifying the separate strains and the individual epidemics caused by those strains, and the history and the tracking and the connections. Apart from the epidemiological linking, the genetic linking has been really important in identifying where cases have come from and who they're linked with. And then the modelling, the mathematical modelling, has also been incredibly influential in many countries and very influential in New Zealand. The Prime Minister fronts up on a regular basis and refers to mathematical modelling, and we've got a team working on that, presenting their work and doing all sorts of different analyses about what-if scenarios and so forth. We have widespread community testing, PCR testing through nasopharyngeal swabs, moving to saliva-based testing, particularly for the border workers and many essential workers who need to be frequently swabbed. And you can see the level of testing going up and down. We've got a lot of testing going on at the moment, but of course with lockdown, fewer people are getting sick and they're not symptomatic, and the testing is really concentrating on a few suburbs where most of the handful of community cases seem to be occurring. So we've got old tools and new tools in our public health armamentarium to try and deal with this infectious disease pandemic. But my big question really is that all there is to public health? We have pandemic control measures, old and new, but what else do we want to think about when we talk about public health? And when I refer to public health, I think much more broadly, and this definition is a very useful one. It's quite a well-known one. Public health is defined by Sir Donald Aitchison in a seminal report to the UK government in the 1990s. And he said that public health is the science and art of preventing disease, prolonging life, and promoting health through the organised efforts of society. And I want to tease out some of those strands in my talk today. One of the other frameworks for thinking about, well, what do we do in public health, I draw on frequently is what's called the Ottawa Charter for Health Promotion. This was an agreed framework for public health strategies, particularly for the promotion of health, formulated in Ottawa in 1986. And it's got a number of strategies. The outermost ring, you can see building healthy public policy, and that's all about intersectoral action. And I'll come to the importance of working across sectors, not just within the health sector, if we want to tackle the big challenges of public health of our day and into the future. Health services figure in the Ottawa Charter, but it's all about reorienting the health services focus from just the treatment focus to think a bit more about health promotion, well-being, investing more in people's maintenance of good health. Reorienting health services to be more accessible and acceptable. And then we have a strand here in the middle called create supportive environments, which is a really important consideration. Individuals don't operate in isolation. No man is an island, John Donne famously said, the British poet. We operate in our environments, whether they be social, physical, cultural, economic environments, and they have an important role to play in the choices we make, the decisions we make, how we live our lives. And so creating environments that support health and make healthy choices, the easy choices, are a very important part of public health. Strengthening the action at the local community level is also vital, and we will have witnessed that going on where we have good community leadership. We have people falling into line and aligning with public health directives and so forth. But they also need information to be able to act, and so developing personal skills is equally important. So that's the Ottawa Charter. Another framework which I draw on frequently is this one by Dahlgren and Whitehead, which is called sometimes the rainbow model of health. And it's thinking about tackling health not just at the level of the individual and making individual healthy choices, but again, thinking more about the environment in which individuals operate. They age, sex, and constitutional factors, which we all have as part of ourselves, but more broadly, our families, our individual lifestyle factors, such as smoking, alcohol consumption, physical activity, nutrition, but more broadly, our social and community networks, which we know are absolutely fundamental to good health. And then our workplace and our wider socioeconomic, cultural, and environmental conditions are fundamental determinants of health. And sometimes the way we can frame this is thinking about all the upstream factors that influence people's health. Public health looks upstream to the causes of disease, not just at the causes, but also the things that cause the causes. So culture, bias, values, global forces, macroeconomic policies, really upstream. The air that we breathe, the water that we drink, the food that we eat, the built environment, how cities are designed to facilitate physical activity or not, and then how we're based and treated based on our wealth, our race, our gender, our disability, sexuality, age, and employment, and then what's going on in our daily lives with housing, education, and so on and so forth. All these things affect us, and the further we come down to the individual, the more proximate we are, we're coming downstream. And typically, health services are focused on the downstream factors and very often don't really address the upstream factors, but public health's very interested in what's going on upstream. If we flip that around and look at it as a pyramid, the health impact pyramid, the more we focus on socioeconomic factors, the less individual effort is required, because the healthy choices become easier if our environment is supportive of certain health and behavior, and we have a greater population impact. The less the environment supports that, the more intense the counselling and education and clinical interventions are needed. But we get a greater value at an individual level, but a less population-wide impact. And Jeffrey Rose articulated this in some seminal work, and particularly in a paper called Sick Individuals and Sick Populations, and looked at the distribution of risk factors and illness in populations, and talked about shifting the curve. The vast majority of people are at moderate risk. A few people are at high risk. In clinical medicine, we focus our efforts on people in the high risk category, but we often ignore people in the middle risk. Population approach is to shift the whole population to a lower risk category. It might be through reducing the amount of salt in our diets, or getting people to be more mobile. And the more individuals that shift just a little bit can make a bigger difference than just working on a few individuals and trying to get them to change a lot. So public health is intensely interested not just in the big picture policy side of things, but also in understanding human behavior. And at the individual level, theories such as theory of planned behavior, reasoned action, and trans-theoretical model of stages of change model are important in trying to predict what people do. But I think if we look at the more socially relevant theories of behavior, which weave the social into the model, like social cognitive theory, integrated models like the COM-B model, theory of diffusion of information, where people adopt certain behaviors, and systems complexity theory, organizational theories. These are all helpful to us in understanding how people behave when there's a health challenge before us. Now, the other factor that's absolutely fundamental to public health, and that will flow through the rest of my presentation, is this idea of health equity. Richard Wilson and Kate Pickett wrote this book called The Spirit Level, but it was really the end of decades of work looking at the notion of equality and how the less equal a society is, the less healthy the people in that society are. The more equal, the less inequity, the better people are off, from life expectancy to depression, right through to all sorts of other factors which are linked to health but not immediately lumped into the health category, like illiteracy. So it's not just about how wealthy a society is, but how equally the wealth is distributed within that society. And there's lots of good evidence to suggest that health equity, which I've defined here as the equal opportunity everybody has to live their best life, is really an important element. And we need to distinguish equality, of course, from equity. Equality might mean that everybody's given the same height to stand on, but to live the best life, the shorter person or the younger person might need a couple of extra resources, if you like, another couple of rungs up the ladder in order to thrive and flourish. And so health equity is not just about everybody having the same, it's about the outcomes being more equitable. And public health is very concerned with this whole notion of social justice, social equity, distribution of health determinants is really very important, like the physical environment, for ensuring that people have a safe and healthy life, and that vulnerable people are able to access the sort of resources they need to be able to do well and flourish. We focus most of our efforts down the right-hand side with disability and clinical complications needing secondary prevention or primary prevention, less so. But we need to focus much more on those upstream approaches. Now, we may think this is sort of new 20th century, 21st century thinking, but actually the whole idea of public health and the importance of upstream thinking has been around for a very long time. And even in the 1800s, people like Rudolf Virchow were articulating this whole notion of what he called social medicine. Now, Virchow may be familiar to some of you who are pathologists or medically trained, because he was the guy who was a polymath who popularized the idea of the causes, the Virchow's triad for the causes of thrombosis. He also conceptualized the notion of the human cell as being important as the foundational building block of all life. And but this is what he had to say: if medicine is really to accomplish its great task, it needs to intervene in political and social life and to remove the things, the hindrances that impede normal social functioning of vital processes. So he was ahead of his time, and really he got that experience from his hands-on work as a young doctor being sent up to investigate and deal with an outbreak of typhus in a part of Germany called Upper Silesia in the mid-1840s. And when he brought his report back, he ended up saying some very unpopular things, because what he observed was that the outbreak of infectious disease was really the result of economic, social, and cultural factors. And instead of recommending more doctors or hospitals be built, he proposed a revolutionary program of social reconstruction, including better employment, higher wages, better universal education, and so on. You can read all about it in the journal I've cited at the bottom of the slide. It makes for fascinating reading. Talking about history, of course, pandemics have been around for a long time, but perhaps one of the more well-known ones in the 20th century was the 1918-1919 flu pandemic, which of course was spread around the globe by soldiers returning back to North America and Europe from the First World War. And interestingly, if you look at some of the old photographs from that time, they're not too dissimilar to some of the images we see on our screens, people wearing masks, people in isolation facilities, people practicing social distancing, schools being closed, and so forth. In my country, we even had quarantine islands for people coming into the country on boats, and you can go and visit these now. Of course, the Department of Conservation settings and the old buildings have been converted into holiday residences. But when that flu epidemic hit New Zealand, it didn't hit everybody equally. And Maori New Zealanders, who are the indigenous population of New Zealand, our Warangasli equivalent, comprising about 15% of the total population, were incredibly badly impacted. And this is a photograph of a memorial to the large numbers of Maori people who died when influenza ripped through their communities, and many of them died from that. Now, in my working practice, I've been involved in a range of epidemics, both in New Zealand and overseas. But when I came back from working in Papua New Guinea, after 8 years there, doing largely infectious diseases and community medicine practice, I was caught up in a meningococcal disease, a serogroup B meningococcal disease epidemic. It's a horrible disease that's invariably fatal unless you get antibiotics into people and provide them with circulatory support to deal with their septicemic shock very, very quickly. But even then, it's no guarantee of success. And I was involved in the public health response in my part of New Zealand as a younger public health specialist. And when we looked at the numbers of cases, we could see over the years there was a persistent theme by ethnicity. In other words, mostly children involved in this epidemic, and they were predominantly Maori or Pacific Island children. Pacific people from the Pacific Islands comprise around about 7.5% of the New Zealand population and tend to be on lower incomes, more crowded houses, and so forth. And if we look at the distribution of cases by deprivation, area-based deprivation score, we can see that year after year, even though the curve is flattening, particularly the pink line at the top in 2001 at the height of the epidemic, the vast majority of cases were occurring in children, Maori Pacific ethnicity, who were in the most deprived communities. So it wasn't the case that everyone had an equal risk of being infected. Indeed, there was a major social gradient and a major health inequity. And when we did the case control work to understand what the most important factors were underpinning the risk of getting meningococcal disease, it was household crowding overwhelmingly, an odds ratio of 11, 10.7. If you added additional adults into a normal home, 3-bedroom home, if you added another family, and we had 2 families of 6 residing in the same house, which is quite common with large Pacific families, you would increase the risk to the child in that house by almost 11-fold. And you can see the way these cases were mapped out according to crowding quintiles. You can see the clustering in the most crowded houses in our city were where most of the cases were occurring. So the public health response was like that Ottawa Charter, multi-stranded. We focused on downstream and midstream and upstream interventions. We did what we could before we had a vaccine, and then we actually developed a vaccine in association with Chiron Corporation. But before we had a vaccine, we had to do all the old-fashioned public health sorts of things. And that included locally focused community-level knowledge-raising campaigns to empower people to seek help urgently after recognizing the early features of meningococcal disease. We worked to reorientate the health services so that practitioners in the community had a heightened alert level for cases of meningococcal disease and were able to treat them pre-hospital with antibiotics. But we also worked on household crowding. I did a large community project by training unemployed local community people to go around thousands and thousands of homes to share the information about not waiting at home if your child was sick, go straight to the hospital, see your doctor as soon as possible. But I also was involved in a major multi-million-dollar program of rehousing crowded families. So we focused upstream at the environmental factors that were underpinning this epidemic. not just the downstream, more clinically oriented factors. And what we found in an evaluation of the epidemic over time and the intervention package that was focused on this condition was that the families who were rehoused in the bigger housing had around about 40% fewer housing-related hospitalizations in 1 year. They increased their attendance at general practice and outpatient departments and better immunization rates, and that's through better connection with the health services. And there were no cases of meningococcal disease in the 3 years over a 3-year evaluation period as a result of rehousing. So that's one epidemic. There's some historical epidemics like influenza. We've learned some lessons from that. Hopefully in countries like mine and yours, I know you have dengue and other epidemics from time to time. We learn these lessons. How do we apply those lessons to the situation we're facing? And I'm just going to focus now on the issue of immunization. I'm involved, as was mentioned in the introduction, with the Lancet Commission on COVID-19. I'm a co-chair of a task force looking at non-pharmaceutical interventions, but we work very closely with the task force focused on vaccination as well, because the two really go hand in hand. And I have to say that as a result of my listening to and engaging with all the wonderful vaccine experts around the globe over the last 15 months that I've been part of the Global Lancet Commission, we could say that COVID vaccines have been a brilliant scientific achievement, but at this point in time, they also show up our failure to work together at a global level. So we've had newly developed vaccines that have been produced in huge quantities in record time. And we're all beneficiaries of those wonderful vaccines to protect us from severe disease and even death. Probably around approaching 45% of the world's population has had at least one dose of a vaccine at this point in time. I know that countries like India and China have been churning through the hundreds of thousands of people very, very quickly, so the numbers have been going up. 5.7 billion doses have already been administered. But only around about 2% of people in low-income countries have had at least one dose. So this is data from September the 13th, just a few days ago, from a wonderful site I'd direct you to called Our World and data run through Johns Hopkins. And then we look at the distribution of where vaccination has occurred. You can see Malaysia right there in the middle between Germany and the United States, around about 65%. New Zealand lagging behind, but I think catching up quickly, 57% with at least one dose. A little fewer we're going, or systems go at the moment, and getting very, very large numbers of people vaccinated. But the horrific thing is this gradient. And when you look at the cluster of countries at the top, Emirates, Portugal, Qatar, Spain, Singapore, etc., Denmark, down at the bottom, Egypt, Kenya, Nigeria, Tanzania, and we could also list pretty much all the other sub-Saharan African countries apart from South Africa, which is just above their league table, 18%. So massive global inequality in vaccine distribution. And this has been the result largely not of will at the level of the World Health Organization, but rather at the level of nation states and so-called vaccine nationalism, which threatens global solidarity and national unity. In effect, I was on a teleconference last night at which a very senior World Health Organization official said, "We are sitting on top of one of the greatest inequities of humankind," referring to the maldistribution of COVID vaccines around the globe. It's not for want of trying that the WHO has tried hard, but countries have pushed in to the front of the queue and are giving vaccines to people perhaps not as at great risk as those people in low and middle-income countries. So high-income countries are taking away life-saving vaccines from the most vulnerable and using them in the ways that really they weren't designed for. Those COVID vaccines were designed to prevent us from dying from COVID-19, the most high risk of us, with comorbidities or very old age, or from being sick, needing to go to hospital and needing respiratory support. That's fundamentally the outcomes that they were designed to achieve, not so much infection control, although that is a somewhat a byproduct of their use, which I'll come back to. As a result of this inequity, societies are now being divided into those who've been vaccinated and those who aren't, and that will probably exacerbate the sort of tension between those two groups when vaccine passports enable some people to travel and some people to not be able to travel. And people on the call last night were very concerned that this whole experience is going to erode the fragile multilateralism and global solidarity that we desperately need to tackle our other global threats, such as climate change and the refugee crisis, effectively and successfully. So, big picture, heavy story, a bit of a worry. I'll come back to global vaccines. I'm just going to focus on where we're up to in New Zealand for a short period of time. So here we are. We've got our vaccine supply. We've now got guaranteed supplies to vaccinate the whole population with 2 doses of Pfizer vaccine, and more besides, because we're going to give the rest away, and we are, to many of our Pacific Island neighbours who are less well off than we are. But within our small country of 5 million, we have health inequities. We have inequities of vaccine distribution within our country. And if you look at the overall picture on the left, what this is doing is a rate ratio comparing Maori and Pacific people and their first and second doses. So Maori in the brown and orange, Pacific people in the blue. First dose is light blue, dark blue is the second dose. And the comparator, non-Maori, non-Pacific New Zealanders, the majority of the population, people who look a bit like me. And you can see that that rate ratio is negative. It's below the line of equality of 1. And so that shows us that we have work to do to get equity of vaccine distribution. And if that continues to play out, we are going to have health outcome inequities with COVID-19 if it circulates and continues to trickle through into our community. And we may be having memorial stones to Maori who died excessively, as they did in the 1918-19 flu pandemic, or for the babies who died in our meningococcal disease epidemic of 15 to 20 years ago. And this is a colleague of mine at the School of Population Health, Dr. Rhys Jones, who's a Maori health researcher. And he made this comment on Twitter recently: why is equity always an afterthought? Why don't we think of it as the first thing that we put in place to ensure that the inevitable inequity is actually addressed early on, rather than picking up the pieces towards the end of the intervention and trying to make it up as we go along. Probably got a minute or two here just to touch on the whole issue of vaccine hesitancy, which has been a big deal we've been trying to grapple with in New Zealand, as I'm sure you're facing in your country as well. Supply failures are a major challenge, as I've described. What about demand failures? World Health Organization says vaccine hesitancy is one of the top 10 threats to global health. It's that belief that a vaccine may be unnecessary, ineffective, or unsafe, and the reluctance or refusal to take the vaccine despite it being available. And it's a very common phenomenon, but it is also something that's distributed unequally in the society. So it's more common in women, but it's also more common with people with lower levels of education and income and in ethnic minority populations. And the World Health Organization model for understanding the determinants of vaccine hesitancy focus in, to a certain extent, on blaming individuals for their complacency, rather than focusing on the environment. And I think a public health approach to vaccine hesitancy would take a comprehensive approach focused on equity to enable and lead people to create the environments in which people want to make the right choices, to get communities involved in leading and advocating for vaccination, health system pivoting to become much more available, affordable, accessible, and acceptable, and then having skilled communications with these well-informed communities. We draw on evidence about what works, but we also tap into the behavioral sciences, and we know that making vaccination easy, attractive, social, and timely will shape social norms and acceptance. And here we've got a picture of a drive-in vaccination centre led by our Tongan community. And here the people are lined up in their cars with the Tongan flag in a racecourse just not far from where I live. They've had thousands of people come through that day, whereas previous days only hundreds of people turned up to the standard centres. So building trust and confidence, making people feel comfortable, working with communities, especially people on the margins, is so vital to an effective public health response to vaccine hesitancy. And this is a colleague of mine, Dr. Rawiri Jansen, who's a GP and advocate for Māori health on a marae, where they have turned around and delivered vaccinations and swabbing for COVID-19 on the marae to make people feel comfortable about coming in and having their procedures done. So we've published some of the work from the Lancet Commission Task Force. And one of the statements at the end of that paper we published earlier this year was, I think, quite prescient. It said, to mitigate the negative impact of COVID-19 restrictions and build preparedness for future pandemics, leaders at regional and global levels have to weigh up the benefits of and the risks of restrictions, but they've also got to provide means to tackle existing and enduring inequities, provide clear, consistent guidance to the public, strengthen capacity in research and application, the analytical and behavioural sciences. Despite the many challenges, there's a window of opportunity for countries to work collectively to build back better with more robust and equitable processes, policies, public health infrastructure, and health systems. And I see you doing that at you're contributing to your national good with a greater focus on putting students through who are learning about preventative healthcare for a healthy nation, safeguarding the well-being of Malaysia, and democratizing knowledge. So all heading in the right direction for the work that you're doing at your university towards that national aspiration. The Lancet Commission on COVID-19 at the beginning of this year said that governments need to urgently fund WHO and the access to the tools, the COVID-19 accelerated tools, including COVAX, and then empower funding agencies to invest in upscaling and dealing with funding to facilitate rapid vaccination. But it's going to require global cooperation. And then Delta hit. And we published this piece in The Conversation a couple of months ago, which talked about the emergence of variants of concern being a game changer. It certainly has made our job much, much harder. But even so, there's plenty of evidence that the existing vaccines are good enough to do most of the job that we want them to, hand in hand with our old-fashioned and our newer technological approaches, such as sequencing and contact tracing using mobile phones and PCR testing and so forth. The old public health, the new technologies, and the vaccine technologies need to all go together if we're going to beat this bug and return to some sense of normality. So what have we learned from COVID-19 so far? And I'm just going to wrap up now. We neglect lessons from our history at our peril. How easily we forget the past and forget the key lessons and incorporate those in our response. We tend to repeat history all over again. We need to think very clearly about what we've learned from our past epidemics and build that into our future responses. And public health, I tried to argue this afternoon, is critical to human health, but it's been neglected by most countries that disinvested in public health. So when the going has been good, public health gets neglected. It's only when things go bad that investment is needed. But it takes a while to scale up, to build capacity and capability. The core public health value of equity is almost always an afterthought by governments. And we're very good as nations and as a global community at technical quick fixes like new vaccines, but we're bad at delivering them equitably over the long haul. And we also ignore the underlying conditions that lead to health inequities. But health is global, yet we've got weak global health governance. And nations are driven not by equity, but by self-interest. But viruses don't respect borders, nor do they respect species. So, watch this space. We're going to be learning more lessons to come, unfortunately. So, to close, public health. We had a definition at the beginning. It's the science and art of preventing disease, prolonging life, and promoting health. But I think we should add and update that definition to and reducing inequities, and a tweak at the end through the organized efforts of not just society, but thinking globally of societies. And then I'll close with this statement, which we've been hearing a lot of lately, but I think is true now more than ever before. No one is safe until everyone is safe, and public health is such an important, not only tool or set of strategies, but also an underpinning philosophy that puts the health of the least well off first. No one is safe until everyone is safe. Thank you very much. Happy to take questions.
Okay, thank you so much, Prof. Bullen, for that really interesting. I enjoyed the historical photos of the earlier outbreaks very much. And I worry that the photos that we're taking now in the future will become historical mementos of this particular era that we're going through at the moment. So I'd like to open up the floor to my co-host, or my Dr. T, and also Prof. Noran, if you'd like to, if you have any questions or comments for Prof. Bullen.
Thanks, Prof. Azlina. Thank you, Prof. Bullen, for the very interesting talk and bringing us through from what it was before, the histories, and where we are right now. And I do agree with the last bit of your last slide. I really liked it. Where you improved on the statement. I've got one question. I think from your talk you mentioned that most all pandemics, especially now that we are in the COVID-19 pandemic, is socially patterned. We see the risks faced by different groups of people are actually different. People have different needs, different capacity, and different expectations. I was wondering what kind of communication strategies that we can do that we should focus on, especially when we looked at different groups of people. What are your thoughts on that, Prof?
Yeah, I think it's a great question, and it's a real challenge, actually. I think we've got to get much more sophisticated at our communications, but basically, I think it boils down to risk communication. We often we complicate things in our communication. But I think of public communications, the importance is to be early with our communications, so that we are not trying to be perceived as hiding anything, that we're very clear and unambiguous as a serious, and that we're very open. So that's a little mnemonic of ECHO, which I fall back on from time to time, but it's very useful framework. And I've seen that played out by our Prime Minister and our Director General of Health, Dr. Ashley Bloomfield, who's become a bit of an icon. I actually did my MPH with him, and I know him to be a person of great integrity. And he'll probably get a knighthood or something at the end of all this, but he's become an excellent communicator. And we had a young person developed myocarditis a couple of weeks ago after having had the Pfizer vaccine. And rather than trying to bury that issue, he stepped up to the plate and said, look, this is what's happened. We've got a case, we're investigating it, the person's being treated. However, I'd just like to point out that myocarditis is actually more common in people who get COVID infection rather than people who are vaccinated. So the risks are multiply higher in people who get infected with COVID compared to people who get the vaccination. So, but we are watching this space, we're monitoring it very carefully. And of course, if there's anything else of concern or any patterns, we will take action and let you know. That information is popped up onto the ministry website. So good, early, clear, honest, open communication. And I think it's particularly important where there's fear and where there is also other sources of competing, information. And we've seen this with this particular pandemic, perhaps more than any other, because there's a pandemic of fear and misinformation. that we have to kind of have countermeasures to tackle. So I think there's an educative role for people, health professionals, to educate our families, our neighbours, our colleagues with where to access reliable information. And so communicating, even at our neighbourhood level, when we can, with our masks on, about sources of reliable, balanced information to try and head off the misinformation that's out there, particularly on social media, coming from various malicious sources, completely flawed and wrong. I think that's really an important task in communication as well, is to expect misinformation, misunderstanding, and try and address it through a kind of public education strategy, but also at whatever level you have, engagement with, whether it's your family. Again, that multiplier effect, even if you're just having one conversation, that person will converse with others and reach out through social media to other people, and hopefully you get that sort of networking effect working and to tip the balance in favor of robust, rigorous, science-based evidence rather than misinformation and malicious and mischievous sources dominating people's thinking. Oh, just another thought. Of course, within society, you have different languages and cultural groups, so it's really important to think about health literacy and particularly language matching. And if you're dealing with young people, you might use different language from older people. If you're talking about different language groups, cultural groups, obviously you have to adapt and contextualize for each group. So there's quite a lot of work to be done to do that, not just assume that the general messaging and the dominant language of a nation is what everybody's going to access, or the route or channel they use will be the one that they access. You have to think about multi-channels, multi-streams of communicating.
Yes, I think that's right, Prof. Bullen. Actually, I have a friend who's an anthropologist who's been working with the Orang Asli community here in Malaysia, who have been terribly affected by COVID-19. And actually, they've come out with like TikTok videos, sort of how to deliver the message, really very effective, and very cute as well. I saw one recently with someone using a blowpipe to shoot a virus in the air. So, I completely agree with you. You have to tailor the delivery to the different groups. Okay, maybe we can take, there have been a few comments and questions. So maybe we'll take the one about from S2378738, a very robot number. That must be a matrix number. So thank you for asking that question. So what do you think about roles of asocial enterprises in public health science delivery?
Social enterprises, okay.
Yeah, asocial enterprises, yeah.
Do they mean asocial or?
Asocial, I think.
Or are they talking about my understanding of what that term, and I'm thinking social enterprises might be like public good orientated businesses that their goal is not so much to make a profit but to actually benefit the health or well-being of the population. Is that what we're talking about here?
Yes, I think I had to Google actually what asocial means. I think that means where there's no contact. That's my interpretation of that phrase. Maybe S23. Maybe you can clarify, and we'll get back to that.
That would be good. I guess just one kind of observation would be that we're all needed in this exercise. There's no one group that shouldn't be involved, and we need businesses, non-government organizations, faith-based organizations. Everybody needs to be playing their part and contributing in some way as best they can with the communities that they reach out to and influence. And if we're all saying essentially the same thing, but in tailored ways to our particular communities of interest, then I think we can really make a difference. I think that with the communication, with the support that people need, particularly the social support that people need at times when they're in when there's problems with lockdown and so forth. Yes, well, what do you think about the role of social enterprise? I think absolutely critical. I think they have a huge and growing role to play, and I've seen a number of social enterprises in my country with various innovative, they're often at the cutting edge of communications innovation and able to do certain things, for example, that academic institutions are too slow to do or not creative enough to do. And they can move quite quickly and nimbly. So I think, yeah, absolutely support the role of all these different groups.
Yeah, in Malaysia, we have a phrase, kita jaga kita, which means we protect each other. Yeah.
Wonderful.
And yeah.
And I'm sure,
okay.
you know, like vehicles such as, you know, mosques and churches and temples are also important settings because it's where people, well, they typically used to gather, but they may not be able to physically gather, but they form a community around that faith-based organization. And that's another important channel for getting out reliable information to those communities and encouraging them to do the right thing for each other.
That's right. So just a few other comments, just saying thank you so much for your sharing. And we actually have Dr. Ling Hao Ki. She's, I think, joining us all the way from Sarawak. So she's asking, how do we begin to address the structural inequities and engage the CSO and government to begin the process so that no one is left behind?
Great question, and I certainly don't have all the answers, but from my experience, it's about, you know, trying to have influence through not just producing the evidence. As an academic researcher, I'm in the business of generating evidence to inform action, whether it's at the level of clinical services and programs or policy change. We want to have societal impact with our work, whether we're in a laboratory or whether our community is our laboratory. We want to produce evidence and have the channels of influence and impact to go all the way up to the top so that the science and information can feed through into evidence-based decisions. And so for policy change, for better housing, more equal income distribution, for social welfare support where it's needed, for equal opportunities for education. All those things require, you know, conversations and building trust. So we build trust with communities so that communities can trust us, but we also need to build trusted relationships with government. We don't have to buy in to all the policies that government enacts, but then we have a communication channel where we can exert some influence and they think we're credible sources of information. And it's a long journey and it's a kind of a long lever to try and work on. And it's a kind of a, you know, multi-generational almost process in some cases. I'm thinking of my area of tobacco control. We're trying to tackle poverty and inequality through tobacco because tobacco is a source of intergenerational poverty and inequity in society. And so we're doing that through trying to achieve the long game of social inequity through a behavioral risk, if you like, by getting better tobacco control policies so that people aren't dying prematurely at the prime of their life and are able to live years longer productively to contribute to society and sustain their family for their education and health and so forth. And so having that bigger picture in view and playing your part in the puzzle and joining everybody up towards the same goal, I think is really, really important. And whether we're working in a laboratory or in the community or somewhere in between, you know, in the policy department, having those bigger visions for what we can achieve collectively is really important. So an example I used of meningococcal disease, we actually tackled housing, which is a major determinant of health, household crowding. And that was through a remarkable alignment of Housing New Zealand, our state housing provider board, being totally sold on the vision of social housing, driven by an ex-Prime Minister who was passionate and determined, a chief executive who was absolutely aligned with that vision, and then health professionals like myself and many others providing the evidence to try and inform the policy. And that was a rare window in my career where I could see that sort of it doesn't always happen that way, obviously. So I would encourage you to keep plugging away in wherever you have the opportunity to do that sort of thing.
So I wonder if I can ask, sorry, Dr. Key, go ahead.
Oh no, Chris, there's also a question or rather a comment in the Q&A box. So sounds like this. I think nations spend more money on arms than on health promotion.
Yes.
What do you think about this?
Well, it's a sad reality. Absolutely, a lot more money on weapons to kill people or to exert their power and flex their political muscles and dominance, rather than building or rebuilding nations. And I'm just thinking of the sad tale of Afghanistan at the moment. You think of all the billions of dollars that were spent on essentially destroying that country over the last couple of decades that could have been invested in nation building. And I know some was, but a fraction of the amount of money that went on military power. It just seems to me like a hugely sad and lost opportunity, and now is unfolding to be an even worse tragedy for many, many people. And so I think that's an absolutely true statement, which we need to push against. And, people like ourselves from the health professions have stood up and been advocates against nuclear war and nuclear armament in the past. And we need to speak out about these things and play our part in those bigger picture issues, just as we might do with climate change, which is probably, along with nuclear weaponry, the other kind of defining health challenge of our generation.
Can I just come back to your earlier comment about the social housing, and maybe Prof. Noran can also give her insights. Some of the largest outbreaks that have happened in Malaysia have been within the migrant worker community because of the way that they are housed, and when you talk about moving forward and coming up with new policies, actually, that's going to have to engage these larger factory, companies, right? And do you know, Prof. Noran, if there are any discussions that are happening in terms of coming up with more strict regulations about the housing of our migrant workers?
Thanks, Azlina. Yes, the issue about migrant workers and how they are housed in Malaysia is one huge thing. I mean, unlike Singapore, where we hear the initial part last year where they had outbreaks among the migrants, it's much more easier to control there as compared us here in Malaysia. And the thing about the housing and the factories, there are already laws governing that, except that the enforcement component it's the issue. So I think, Chris, what do you think about? I mean, we have everything on paper. Yes. So, Prof. Chris, any comments
I think
on that?
we're going to have to think about redesigning our environment. And one of those factors is with these respiratory viruses, we need to think about ventilation, and we need to think about physical distancing. And obviously, some of these residential situations are probably far from desirable, and absolutely create the grounds for which infectious diseases can multiply and spread. And so I think absolutely, government and businesses and whoever's responsible, companies that have migrant workers that house them, need to be held to account for creating more supportive environments for their workers to live in. Otherwise, they're going to be faced with time and again these kind of challenges. I mean, it's a very simple equation. When you look at the spread of these viruses, respiratory viruses, the more you just speed out, the less likelihood of travel in the person. And the more ventilation you can provide, the less likely you are to get everybody getting infected if there is a case. And so I think there's a relatively simple structural interventions that can be done that can mitigate at least some of the potential catastrophe that we otherwise would face. And Singapore has demonstrated that they can do it through doing it the right way. So we have to learn lessons from this. Is a grand natural experiment that's going on at a global level. So we need to look to countries like Taiwan and Singapore and others where they have achieved remarkable success despite the odds, and perhaps not so much resourcing in some cases.
Yeah, there's a lot more work that needs to be done in that area, I think. So talking about other countries, there's a comment by Chi Hao. Taiwan is a country that's performed well without being able to participate in international health organizations like the WHO. Did New Zealand learn anything from them? And did New Zealand support the admission of Taiwan into this organization? Do you know?
Actually, I'm not sure, because we have a free trade agreement with China, and so it's politically, difficult. However, I know we have been talking with the public health authorities in Taiwan, because we've been watching what's been going on there, as we have with Singapore and others, and trying to learn the lessons and thinking about what's been working well for them in terms of some of those old public health measures and the new technology as well. And Taiwan's, done extremely well very early on, and contained community transmission for a long period of time. Recent outbreak, but they got on top of it pretty effectively. So I think the social life in Taiwan, people are generally pretty cooperative, even though people are densely packed into a lot of apartment blocks. I know I've been to Taipei quite a few times. It's a big, busy city. But people, respect the leadership and are happy to cooperate. And I think we've seen that in New Zealand, different to many other Western countries. We've had a respected leader. Our Prime Minister, Jacinda Ardern, I think has, been given respect for her response to a terrible tragedy we had last year with a massacre at a mosque. We've had a volcanic eruption which killed and damaged a number of people. Again, she was amazing. And then in the face of this pandemic, she's been absolutely brilliant with her communication, her empathy, talking about the nation as a team of 5 million. So those kind of intangible leadership, communication, social, behavioral factors are actually really, really important. Whereas you look at countries like the US, where it's fragmented and fractured along political lines and lines of wealth, and the East and West Coast are very different from the Midwest and the South. You look at the epidemiology is very different, and it relates to vaccine uptake, which is due to misinformation and ideological stances that people are taking. So it's not a unified situation there, and so it's playing out very differently within a country, state by state, according to the social factors which underpin people's vaccine hesitancy, essentially.
Right. Yeah. I mean, I think leadership is really very important in this circumstance, and can I just get your opinion about do you think that the WHO has done enough to sort of try to influence the different countries, or have they sort of left it to the individual countries to sort it out themselves, basically?
I feel sorry for the WHO. I have colleagues who are there and in Geneva, and also have worked with WHO regionally and internationally. And look, I know it's a big bureaucracy and it's complex and it's hard to move because it's a UN organization. You're bound by what the members decide. You're also underfunded because a number of the countries don't pay their way reliably, or they pay them late or under duress. And so, it's got a number of institutional challenges, but despite that, there are amazingly talented people of goodwill who are trying their very hardest at the moment to sort of muster the countries and their leaders to listen to the evidence and to make the right decisions. And so COVAX has been an example of the World Health Organization's leadership. The beginning of the epidemic and the slow time that it took to recognize that this was going to play out the way it has. I think one could look back and criticize the WHO for maybe being a little bit too cautious and coming under the influence of, the Chinese government's political sensitivities. But when they got into action, I think they've tried really hard, but they've been frustrated, and I know they're immensely frustrated by vaccine nationalism, particularly with regard to equitable distribution of vaccines to poorer countries.
Yes. Okay. So there are no other questions on in the Q&A or in the chat box? Prof. Noran, Dr. T?
Yeah, I've got one last question for Prof. Bullen. We've been hearing the term living with COVID everywhere. I mean,
Yes,
people
yes,
are
yes.
now throwing the term living with COVID. My question to you is, what does it actually mean, and what does it actually mean to healthcare providers?
Yes, I think that's a really good question. I think living with COVID in, say, the UK probably means something very different to living with COVID where in my part of the world. I have a son who lives in London. He actually got COVID infection. He's been vaccinated. He's fine. He hasn't developed long COVID. But, you know, their hospitals, their ICUs are still overwhelmed, and they're going to get worse probably in the next few months. You know, this is part of the fallout of the pandemic, is if you decide as a country to live with COVID and put up with a certain number of cases and a certain number of deaths, you're going to get deaths from people deaths that were preventable, but they couldn't get to ICU because they were full of people with COVID complications. So the health services are going to be overwhelmed, and that's going to lead to collateral damage that will play out for people with diabetes and asthma and all those other issues that needed to be attended to but were deferred, or people presented too late. And so I think, you know, the whole aim of the game should be, if you can live with COVID but have responsive health services that can cope with the burden that naturally will occur once there is circulating disease in the population. Even though most people will only be mildly ill, there will be a proportion of people, even healthy people, who get very sick, and then the high-risk people with comorbidities and old age who might get very, very sick. And you have to accept that trade-off if you want to so-called live with COVID. In New Zealand, we've made a decision. We're going to try and eliminate transmission and stamp it out, and keep it stamped out quickly through excellent contact tracing and containment measures, but try and avoid, through vaccination, try and avoid lockdowns, which are economically punishing and bad for people's well-being. And so we're trying to get that balance and explore what that looks like, and that will be living with COVID for us, but a very different kind of living with COVID than, say, in contrast, a country like the UK is trying to do. I'm not sure if Malaysia sits somewhere in the middle, but there will be a continuum of experiences. And I guess, like we did last year, there was some comparing and contrasting between countries. And we'll see how that plays out as this year continues and as people get increasingly vaccinated. And Delta has come into the mix. It's going to be a very different story in 2021 compared with 2020, and then 2022 will be different again. And I think the important thing is that, you know, we learn lessons that are enduring lessons for how we can build better societies, more equitable societies, to make sure that we don't make the same mistakes twice or 3 times or 4 times.
Okay. There's another question. Do you think the vaccine diplomacy played out between the US, China, and Russia is benefiting or hurting the global vaccination effort? It's a very...
Yes, it's interesting to see how these superpowers are using vaccines as not weapons of mass destruction, but weapons of mass influence.
Yes.
And I think that's sad, actually. I think there should be no strings attached. Vaccines are a public good, and they shouldn't be used to try and make a profit for a company, nor should they be used to wield geopolitical influence. And I think that those 3 superpowers have set a very bad example. And we, as smaller nations, should be speaking up about that and trying to have our voice heard in international fora to try and shift the direction of those 3 oil tankers and nudge them to be much more willing to do this for the greater good of the globe. Because, as I said, you know, viruses don't respect national borders. We're all in this together. We're not safe until everyone's safe.
Yeah, And it's not just about sharing the vaccine, is it? There's always something else behind.
Strings attached.
Yes, absolutely.
That's right.
Okay. I think that's it. So any, Dr. T, Prof. Noran, any more? Okay. So, so I'd like to end this really very interesting conversation that we've had about COVID-19 efforts. You know, the efforts that's going on in New Zealand as well as across the world, and what it means for all of us moving forward, right? As a scientist, I've found it also very interesting because it's brought science a little bit more into the realm of public conversation as well. I mean, I've had conversations with my father about PCR, and so, you know, if we sort of think, yeah, so if you know, there will be, I hope, some positives that will come out from this. You know, people understand viruses a lot more, I think, now, and you know, you know, we won't know until a few years down the line, really, right?
Correct.
The true impact of what we've gone through the last couple of years. So with that, I think I'll end the webinar today. Thank you so much, Prof. Bullen. It's been wonderful hearing your views and your insights.
My pleasure.
Okay, thank you, Prof. Noran and Dr. T for co-hosting the webinar, and of course to everyone who has joined us this afternoon. Thank you, everyone. Stay safe. Bye-bye.
Bye-bye.
Thank you, Prof.
My pleasure. Thank you very much. I enjoyed the discussion. Great questions.
Yeah, it's there were about, I think at the peak,
people, I think.
yeah, about 90 at the peak, I think.
Okay.
92.
Oh, good.
Yeah. Yeah,
That's
yeah.
great.
That's great. I
Excellent.
mean, there's a huge
And
public
there are
health-
about 10 to 15 in the YouTube channel. Yeah.
Okay. Oh, great.
So we have
And
more
you know,
than
this is
100.
always the way. Okay. So, you know, often webinars now are much better attended than lectures in person. So you actually can have a bigger influence.
That's
People
right.
are
And
often freer to ask questions as well on the chat. So it's quite good.
that's right. That's true. Yeah. I mean, in
Okay.
Malaysian culture, you kind of, they tend not to talk openly too much. Yeah.
Very good. Well, look, that's been
All right.
a pleasure.
Thank you so much,
I will
Prof.
head off for a walk outside
you.
before the sun goes down.
Yes, yes,
you.
please do. I'm sure
That's fine.
you need to rest after this. Yeah. Thank you so much.
Thanks very much.
So
Thank you
we'll
so
I'll be
much.
in touch
you.
on Monday and Tuesday.
That's
Yeah.
right. That's right. So
Okay.
we'll be sending some documents to you, but no rush, you know, until
No,
next
that's
week.